Yeah.
Well, welcome everyone to the Positive Behavioral Interventions in Community Settings Family Caregiving Series, also known as our Parent Cafe. You are muted. You've been muted. Please use the chat to communicate with us. If you feel like you would like, keep your camera on. We love to have interaction throughout this entirety. So just throw something in the chat. Myself or one of the other members of the IBT team, TKP team that are here to help with this series are going to be giving it right now. First off, we would love to thank Kansas Children's Cabinet and Trust Fund, as well as the All In for Kansas Kids Quality Subgrant. They are amazing sponsors of this, with not only our Pbs model that is being implemented at our childcare facility, the Kids Place in McLeod, Kansas. They are also wonderful sponsors of this series that we are doing. We are number 2 in a series of 10, possibly 11 of these that we're going to be doing. So keep your eyes out for more information on that. We can move to the next page. So, we'd love to know more about who you are. Write your name, your organization, your email, so we can keep you up to date, like I said, with more and exciting information about things that'll be coming on. Coming up in the future, we have our next presentation going to be taking place on November the 17th. So keep an eye out for that. And, feel free, ask questions in the chat. Kari is very free flowing and very good at these presentations, and we're very excited to have her here today. So feel free to chime in, and I will ask those questions as they come in. We are your hosts today, Integrated Behavioral Technologies, Inc., and the Kids Place, with support of the University of Kansas Medical Center. Dr. Linda Heitzman-Powell was unable to attend today and very sadly sends her well wishes to Kari that she can't be here, but of course she is training people in the field today. So we're excited to have her doing that, to bring out some new people into the world of helping out children with autism. So she's got to do that today. But without further ado, it's my pleasure to introduce Kari Wold. She is been with IBT for 7 years, in the field for 14 years. She is the Clinical Services Supervisor for Integrated Behavioral Technologies and the Kids Place. She oversees and runs the assessment clinic for those two as well, and pretty much does a little bit of everything for IBT and TKP, or at least guides people on how to do that as well. We are very excited to have her here for a very important topic. So I will give it over to Kari, and thank you very much for presenting today, Kari.
Yeah, thanks, John. So as John mentioned, I'm Kari. I have been with IBT for several years. Came into IBT after graduating from my graduate program and have been here ever since. So as John mentioned, I am very laid back when it comes to presenting. So feel free to ask questions either verbally or in the chat. I know that some people might be in commute, and so please do not type in the chat. You are welcome to unmute yourselves and ask questions as you have them come up, or hold them until the end and then ask them then. So I will try periodically to stop and ask who has questions. But we'll go ahead and proceed. You will see several times on this presentation and throughout all the presentations, bubbles that are level up bubbles. And so essentially when you see that, there are different questions that are posed in those sections. And so I may be asking your thoughts or your opinions or what you take away from things when we see those. So in regards to, I'm going to actually skip through a lot of these. So just starting up to the presentation. In regards to the presentation today, we're going to talk about the ins and outs of assessments and diagnostics. So what to look for. Now, I'm not going to cover every single assessment that has ever been created or every diagnosis, because unfortunately, there would not be enough time to do that within the hour. And so I'm going to kind of cover the broad overview of assessment, diagnostically, what to look for when you are seeking assessment. And I am going to talk a little bit about two common childhood diagnoses, so ADHD, so attention deficit hyperactivity disorder, and autism spectrum disorder. Again, very briefly, but just to kind of give a little bit of background and statistics on those two specifically. So a couple of the objectives for today, I actually have 4. So we're going to look at early warning signs and warning signs even in older individuals, who to contact when you have concerns, what to look for when you are looking for an assessment, and then what to expect during the assessment process. Again, this is not, especially number 4, every clinic is a little bit different, and so it's going to be very broad, but just to give you a sense of what it could look like, or perhaps parts of what it could consist of. So just briefly reviewing the Pbs model, if you think about assessment and you think about getting a child assessed or an individual assessed, which tier do you think assessment would likely fall under, and why? So primary being kind of a systems-wide, center-wide based, versus a tertiary, which is specialized, individualized. Okay, so it would be a tertiary prevention because we are going to tailor it to the individual. Now, there are assessments out there that do perhaps look at group and groupings. And a lot of times when we're looking at looking for efficacy, and we're looking at like the initial stages of even looking at whether an assessment measures what we're seeking for it to measure, we might do a primary prevention where we're going to look across individuals who are similar in age, ability, a number of areas, but for diagnostics, it would be tertiary. So it is going to be individualized to the person based on a number of variables. Now, just delineating a few terms you're going to hear me use. ASD stands for Autism Spectrum Disorder. As many of you know, the diagnoses such as Asperger's, previously known as Asperger's, they all fell under this umbrella. So it's a spectrum. Autism is not linear. It is not one end or the other. Every case looks very different. And the symptoms that accompany a particular diagnosis may look different for individual A than it looks for individual B. There may be some overlapping and there might be some similarities, but there will also be differences. So it is truly a spectrum. ADHD, attention deficit hyperactivity disorder. ADD no longer exists for the DSM-5. They all fall under ADHD, which I'll talk a little bit about briefly shortly, the 3 different subtypes of ADHD. The CDC is the Center for Disease Control. The DSM-TR5 is the text revision of the DSM-5, which is the Diagnostics and Statistics Manual, which is what we use when we are formulating a diagnosis. EIBI is early intensive behavioral intervention. So that is that early intervention that we utilize in order to hopefully close that gap that you see with delays in learning. And then NIMH is the National Institute of Mental Health. So you'll hear me talk about these, or you might see these terms, and that's what these mean, but feel free to ask later if you need me to restate them. So just some helpful tools and resources. So the NIMH website actually has some really good information regarding statistics and symptom information for a number of disorders. These are not the only ones. There's actually several, but ADHD, ASD, PTSD, and several others. So if as a parent or a caregiver, or perhaps knowing a parent or caregiver, there are some concerns, this is a good source to look at to see what symptoms are present. Is it enough that it warrants concerns that perhaps I need to talk to my PCP, so my primary care physician, or my pediatrician, or are they not? But it's a really good tool to use so that, you know, as you are helping parent your little, or you're helping caregive for someone else's child, you know that you have resources available to you. But being aware is one of the most proactive things you can you can do as a parent or as a caregiver. So being able to monitor your developing child and being aware of what is typical development and maybe what is atypical is really important so that you can advocate for your child because you are their voice. So that link that I shared on the screen is the link that you could go to access the website. But if you simply Google NIMH, that will take you to that website. It's very well known. So just some very basic statistics. ADHD is a common childhood diagnosis. It can be diagnosed as early as the age of 4. And as I mentioned briefly, there are 3 subtypes. They're inattentive, hyperactive, and combined. So inattentive is truly that. So that lack of ability or maybe inability, difficulty paying attention, attending to tasks for longer periods of time. Hyperactive, very busy, struggles holding still, maybe climbing on things that they shouldn't be climbing on. And then combined is a combination of the 2 with the addition of impulsivity. And so you might end up with some very impulsive behaviors that are oftentimes or could be unsafe. So those are the 3 subtypes of ADHD. And then autism, ASD, is the other one that I'm going to just briefly talk about. So in a 2018 CDC survey, 1 out of every 44 8-year-olds that were surveyed within this were identified as being on the spectrum. And so, again, this is not all encompassing, but this was the most recent survey that I did find. Now, autism is characterized, as it says, by social communication deficits and engagement in restrictive and or repetitive behavior. So this could be limited interests or excessive interests in very specific topics or maybe only one topic. And we'll go a little bit more into some of those warning signs shortly. So early warning signs of ASD. Here are just some indicators, but a lot of parents express concern for their child's development between the ages of 12 and 24 months. There are some parents that actually indicate even earlier that they had some concerns based on some behaviors they were or were not seeing in their developing child. So depending on the child's age, warning signs may vary a little bit differently for that child. But for younger individuals, some of these might be some of the things that you see on the screen. So things such as developmental delays. So maybe they're late to crawl or walk or even talk, or all of them. You might see self-injurious behavior. So maybe they are banging their heads on the floor or on the wall. Maybe they're engaging in a lot of really aggressive behaviors towards others, or they're engaging in some repetitive motor movements, so hand flapping, and not just out of excitement, like I'm jumping because it's bubbles and it's fun, but it's excessive. Again, those delays in speech or excesses in speech. So when you have an excess in speech, it might be that they're saying the same thing over and over again. Now, for anybody that has a small child, we know that there's repeated questions. So when are we going to be home, or why do I have to do this? This is more of engagement in repetitive speech that may be indirected or is not meaningful. So it could be a little who is walking around and saying kangaroo and not directing it, and they're just repeatedly saying it, or perhaps they're looking at the wall and they're saying it. And so excesses in speech is another area of concern. Inspecting items very closely. So bringing things very close to their face and looking at items, perhaps holding it off to the side of their eyes and looking at it from an odd angle, or perhaps they find a item and they're very interested in a part of the item, but they're not engaging that item as a whole. So it's very common for little people to want to explore items and see how they work. But if all they do is focus on that one part all the time, that could be something to be concerned about. Other areas are lack of engagement with peers. Perhaps they lack social awareness altogether. And so maybe in a room with people, they do not turn to the sound of someone's voice, but they will immediately turn to something that has fallen on the floor and they hear the sound. And therefore they're not really responsive to their social partner. So those are all areas. Now, one of the things as a clinician that I look at, and I always make sure to ask, one of the many things is when was the last time your child had their hearing and vision checked? Because I want to ensure that I have ruled out, or that we have ruled out medically, that it is not a hearing issue and that it is not a visual issue. Because obviously if somebody can't see because they need corrective glasses, they may have to hold it up close because they can't see it farther away. But if we know that visually everything appears fine and auditory wise everything appears fine, we at least know that those aren't the explanations as to why that child may be engaging in certain behaviors, or maybe is not engaging in certain behaviors.
So Kari, that's ironic, if you don't mind me. That's ironic that you say that, because I have a nephew who's autistic, and you know, he was showing all these signs. Well, come to find out, he also had ear issues. He had he had to get tubes, but basically he couldn't hear for the first year of his life. So not only was he autistic, but on top of that, they didn't know that he couldn't hear. And so it just delayed him even more. And then they got it fixed, right? And that's when, and then he started getting ABA therapy, and it just took off. Like, he just started succeeding. So it's just ironic that you say that, because it apparently has a big effect.
No, that's awesome. And I appreciate you sharing that. And those are all good points, right? And that's a good example of how that would apply in everyday life. Because, you know, even if ABA had been involved, but he couldn't hear, that would make it very difficult to start teaching. So, so before I go to the next page, we're going to level up. So when you think of the PBS model, if you're thinking of symptom identification, which tier would it fall under? That primary, secondary, or tertiary? So remember, the primary is that global everybody. Tertiary is that's individualized and is mapped onto that singular person.
So would it be tertiary?
I was going number, yes.
Which one did you say? Tertiary?
Yeah.
Yes, yep. So tertiary, exactly. So we have a list of symptoms, but obviously, again, as I mentioned earlier, it's going to be individualized, and we have very specific measures to look at the diagnoses for that exact reason, because it looks different. And so we do have to take into consideration that, well, this person may not have these symptoms, they do have these symptoms. Before I go on to the next slide, does anybody have any questions so far? Okay.
Looks like we're good in the chat.
Perfect. Okay. So we're going to talk a little bit about warning signs of individuals who are older, who perhaps may be on the spectrum. So when I say older, this could be older as in older adolescents, teenagers, or even adults. So for older individuals, some of these might be things like they miss typical social cues. So how many of you have been in a conversation where somebody's like turning away, like, I have to go and like, I need to leave? Missing certain cues, or perhaps or not being able to read them at all, could be a potential sign of spectrum. They may miss clear instances of sarcasm. So for instance, you spill coffee down the front of your shirt, it's white, and you are entirely covered, and you're like, well, that's great. And the person thinks it's literally great. That's clearly not great. And so again, missing clear instances of this is a sarcastic comment could be another sign. Being very rigid and routine. Now, I will be the first to admit I like my routine. I prefer it, and it's how I function. But being so rigid that I'll use myself, an older adult, and my schedule changes and I collapse to the floor, just as an example. And this is an extreme example, but being so rigid that you cannot function, or that it causes such an extreme upset that perhaps you have to have intervention, could potentially be another warning sign. Lack or limited understanding of interpersonal relationships. So some relationships are complex. Most relationships, I would say, are complex, but not having an even basic understanding of a typical, what makes a friend, how would you know someone is a dating partner? Having a lack of understanding of that would be a concern. Difficulty maintaining long-term relationships. Well, if you don't have an ability to understand relationships, maintaining a long-term relationship would be difficult. And I see I have a chat, so I'll get to that in a second. Extreme states of unexplained rigidity, anxiety, and depression. So this would be that it's not better explained by a diagnosis of depression or anxiety. But again, being so rigid that you struggle to function, or perhaps having anxiety that is so excessive or depression that is so excessive, but there is really no explanation in conjunction with other symptoms. And so again, when we're looking at diagnostics, we're going to look at all of these things to figure out what is the best explanation for the symptoms this person is experiencing. Depending on the severity of the cases, some of the symptoms that we talked about earlier with the younger individuals may actually be seen in older individuals. So you may see older individuals who are engaging in what we call self-stimulatory behavior, so stimming. So perhaps they hand flap. They may engage in repetitive speech. And so we look at and we tailor the diagnostic evaluation to capture all of these things with the individuals. I'm going to go to the chat box.
It was more of a agreeable from one of our.
Yes. Okay. So basically, we're all, as humans, we all have our times where we are rigid and we prefer things, but definitely there are warning signs. Again, they vary by the person. And as Kayla mentioned and John mentioned earlier, tertiary is what we're going to be looking at when we're looking at symptom sets. So some of the things, I'm going to move this box so I can actually see my screen. Some of the people you could contact if you have concerns. So community partners are great people to contact. And when I say community partners, I mean the different professionals that are around us. Many of us have some knowledge, or at least could guide you on where to go. So that could be somebody like your pediatrician, your primary care physician, educators, childcare providers, and just other professionals that maybe you communicate with. So by doing this, you could perhaps express your concerns and have them either verify or maybe perhaps give you a little bit of comfort that actually this is typical, if it is typical, or perhaps say, you know what, that is a little bit unusual, or that's a little bit atypical. Let's explore further. This not only allows you to perhaps speak with someone else and walk through and talk through what you're experiencing as a parent or caregiver, but it could also allow you the opportunity to gain a referral. Some clinics do require referrals in order to be on the wait list or on the schedule. Others don't. One way to locate a diagnostic clinic would be to contact your insurance carrier and ask for a list of in-network or out-of-network providers who are listed as being able to do a diagnostic evaluation. I delineated the in-network versus out-of-network because there is some difference in pay and what that would mean for you as a parent or caregiver in regards to responsibility of payment. So those are just some of the folks that you could contact if you have those concerns. So when you are seeking an assessment, there are several things to look for. So, I will say for myself, and I said it's okay to ask. I am always okay with a family asking me questions regarding the assessment process. So what to look for. So what tools and measures they use. It is really important that the clinic that you go to is utilizing measures that are supported, that have had empirical data and research done to ensure that they are measuring what they're intended to measure. There are also certain assessments that are recognized by insurance, for instance, that will permit you the ability and afford you the ability to get coverage for certain service types, whereas others may not be recognized. And so we want to make sure that we're using tools that are recognized measures. Is it a comprehensive evaluation? Are we looking at, a number of assessments? Are we looking at a number of areas of functioning? So when I say areas of functioning, what I mean is, are we looking at the cognitive functioning, adaptive living skills functioning, perhaps the socialization skills or social abilities? Are we looking at, what are we looking at? And so asking what all that assessment would entail is entirely fine, and I would recommend it. if the diagnosis is given, is it going to be recognized by insurance? I get that question quite frequently. And so, is the diagnosis being given by someone that is able to give the diagnosis? Is the clinician certified in administering the assessment? Some assessments are relatively easy to administer, or perhaps it is a parent survey and you plug it into a system. And you still need to be able to interpret it. But others do require some pretty extensive training. So for instance, the ADOS, which is the Autism Diagnostic Observation Schedule, is a measure that does require pretty extensive training to be able to not only administer it, but interpret what you found through that administration. And then are they using the most up-to-date DSM? So DSM-5 or DSM-TR5. The DSM has changed greatly since the first original version, and so it's really important that they're using the manual that is up to date and reflective of what diagnoses we recognize now. Many clinics right now do have a wait, and so please be patient. And I say please be patient, and when I say that, I mean don't give up and get on wait lists so that you can get your child assessed. We are attempting to get people in, and I say we, but clinicians are attempting to get people in as quickly as we can, given the resources that we have. And so, don't give up hope, and definitely, if you feel and you've been expressed those concerns and you have those concerns, by all means, continue to pursue that. Any questions so far before we continue?
Do you know, not just specifically to, obviously the clinic that you work, or the assessment clinic that you work with, but just across the board, what we're looking wait list time for? So if we do have people wondering, or if we have people in the field, they could give them a general idea.
Yeah, so I'm going to say this, and it's a very rough number because I cannot speak for every clinic. But I hear from parents and caregivers who call, and even individuals who are calling for themselves, everything from 6 months to 18-month waits. Now, a lot of places will have cancellation lists, something might come open. There are new clinics always coming around. And so there is a chance that it could be a shorter time frame. But I hear frequently that 18-month wait. So my hope is that as we get more clinicians on board and more psychologists and individuals who are competent and able to administer these assessments, that wait will decrease. But the need is so great, and the number, again, of resources, and by resources I mean people that can administer, is limited. It does limit the number of assessments that are able to be rendered. So I'm glad that you asked that question. That is a great question. All right, so what to expect during the process. So you'll likely have intake paperwork either the day of the appointment or sent to you prior. Some paperwork is really extensive. For instance, ours is relatively long because I am gathering background information. I am gathering information on development, school, family history, things about play, engagement with items, people, as well as information to share with families regarding HIPAA and insurance and all the things that are very important for them as well. I want to give them plenty of time to fill it out so that they feel like they have shared as much information as they would like. And I always tell them, share the more information, the better. Share as much as you can and you want, because it is helpful for me when I'm looking at formulating a diagnosis. What am I seeing in regards to outside of this session? What are they seeing? And that's a big component, and that's something that's very important for me to be able to see. Asking for IEPs, asking for school reports, other caregiver reports, taking all of these things into consideration. When you arrive, you may or may not be in the room with your child. Some children, when they're very, very little, having the parent in the room is incredibly important. Other individuals, teenagers, may be not needing a parent in the room, or perhaps they would do better if they don't have a caregiver in the room because they're a teenager and they would rather talk to the person one-on-one. And so you may or may not be in the exact room with the individual, but you will likely be in the room with them to some degree for part of it. It's just to what length of time it will vary. While you are in the office, you may be asked to complete other parent surveys or questionnaires. So this could be a general behavioral checklist like the CBCL, or a communication questionnaire such as the SRS, which is the social responsiveness scale, or the SCQ, so the social communication questionnaire, and amongst a number of other assessments. And so again, those are not always diagnostic. It might just lend credence to the diagnostic evaluation. So keep in mind that you may be asked to fill out more things once you get there. And then after the administration, you will receive some sort of report. Now, as clinicians, we're not able to release assessment protocols. We are, those are protected under copyright laws, but we do release some sort of report. Now, reports do look different across agencies, but for instance, our reports have the background information, developmental history, school history, family history, and then it breaks down the different assessments that were administered, what they were looking for, what they found, and then what they're saying collectively. So what are we seeing based on those assessments, and then a diagnosis when one is warranted, and then recommendations are at the end. So recommendations are tailored to, and again, tertiary, are tailored to the individual based on age and the diagnosis that was given, if one was given.
Kari, I have a question.
Yes.
How much, sorry, I had to step away to take a call, so I was gone for a couple minutes. So if I missed this, I apologize. But how much of your diagnosis is genetically affected? How many of the diagnosis, what am I trying to say, is genetically due to genetics, right? So, I mean, is autism due to genetics, or is it not?
That's a great question. So I would say there's still a lot of research that needs to be done.
Oh, really?
What causes what. Now, one of the things that you will see in our reports one of the recommendations is getting genetic testing to make sure there is not a better medical explanation for the behaviors and the symptoms that are seen, because there are some cases where there is something else occurring. But for instance, let's say there's a chromosomal deletion or excess. That does not preclude somebody from having a certain diagnosis, but it is good to be mindful of, because that definitely could exacerbate things, or perhaps perhaps it really does better explain something that's going on. And so you know, there are genetic components certainly across many disorders. And if you look at like statistics, and I'm not going to even pretend to name off some of the percentages, but if a parent or caregiver has autism or ADHD or depression, or like, let's say schizophrenia, it does increase the likelihood of a child having that disorder. Each disorder has a different percent as far as if the parent has it, the percentage of the child, or the chance of the child having it is X percent. And so that's one of the reasons why when I'm collecting data and collecting history is, that's one of the reasons I ask about family history is, what are we looking at? If we know of any formal diagnoses, are there any? So great question, Kayla.
Thank you.
Other questions so far? No. Okay. So just some takeaways, and then I would love to hear about any of your takeaways or questions that you have and what you might share. But talk to somebody if you're concerned, whether it be again, a community partner. But if you're concerned about your child's development or a child's development or behaviors, talk with someone about it. A lot of times, PCPs or pediatricians are actually some of the first people to bring up concerns that they might have for a client of theirs. And so a lot of times they'll be the ones that are bringing it up to the parent of, hey, I've got some concerns that I'm seeing things or I'm not seeing things at your well child visit. But definitely feel free and feel comfortable. I would hope you feel comfortable speaking with a community partner, because it really does take a community. Raising a child, there are so many people that interact and interface with your child or with the children we are around. And so using those resources to help your child progress is entirely fine. Again, if you're not sure who to start with your pediatrician, start with your PCP, let them know of those concerns. They might have some measures that you can use to, see if you are seeing enough symptoms that maybe you really should be looking at a diagnostic evaluation, but chat with them about that. If you decide that you do want to go the route of diagnostic evaluation, call your insurance company for a list of providers. They can provide that. You can also, a lot of times, the companies now have some really awesome lists on their online sites for their members. And so you may be able to access it that way. But if you are overwhelmed or you're not really sure where to look, that's okay too. Feel free to call and ask for a representative and see if they will send that to you. And then lastly, but really it's the most important, is you are your child's voice. So ask questions, ask for help, and that is entirely okay, but you are the one that's going to be helping them by doing so. So that is all I have for today as far as my presentation. So what questions or comments or takeaways do you have, or things that I can help answer for you?
Kari, before you we get into questions, so take time to formulate your thoughts, group, and to get into the chat if you have questions, and we can answer those. But I just did want to remind everybody that after our presentation today, we will be sending out a follow-up email that will also have Kari's information in there if you'd like to reach out to her, as well as her presentation. Before we go on to the questions, and I'll thank our sponsors after our question session. If you have not done so and have not signed up prior to this, we'd love to have your email address to keep you abreast of what's going on for our next parent cafes coming up in the upcoming weeks. So thank you. So we open it up. Any questions? First question is, will this recording be available to share for others? Well, thanks to the technological genius known as Kayla Stevens in this group chat, it has not been left up to me this month, and it will be on our website within a week, probably much less than that, knowing Kayla. So I would continue to, and I will drop our website in the chat as well. Any other questions?
I have a question, Kari. Again,
Yeah.
with coming from talking about diagnosis, how many ASD diagnoses come with other behavioral diagnosis? I mean, what is just ASD alone? Is that pretty prevalent, or does it usually come with others?
That's a great question. So that's a really good question. And then I'll come to the chat too. So comorbidity, meaning having multiple, is not uncommon. So with autism specifically, the rate of comorbidity for anxiety, depression, and ADHD is actually relatively high.
Okay.
Now that said, you certainly can have autism alone. Now, the thing with diagnoses and a number of the diagnoses is that there are a large number of symptoms that overlap. So, you might see this symptom in diagnosis A, but you also see it in diagnosis B and C. And so as a clinician, when I am looking at an individual, I'm looking at what is the best explanation. And so I'm looking at number of symptoms. I'm looking at, each individual measure that I've used, kind of what it's pulling. So for instance, thinking of like a cognitive assessment, are there certain areas that are very low versus very high? In addition to like the Vineland, where I'm looking at like adaptive skills. And so I'm looking at all these things, and I'm looking at the symptoms and how they're presenting, and really looking at that DSM at that point, and looking at, is the best explanation that it's it's autism, for instance, and once we start intervention, do perhaps some of those symptoms decrease, or maybe it mitigates them altogether? Or does it appear to be autism, but maybe this little has so much hyperactivity that it appears to actually be autism and, maybe ADHD hyperactive, or primarily hyperactive presentation. And so to answer your question, yes, comorbidity is a thing. And so it's something to be mindful of. But again, I'm going to be looking at what's the best explanation. And so if the best explanation really is one thing, it may be that one thing explains the most of the symptoms, but perhaps it is two things. So
makes sense.
So to answer,
okay, you saw it already, sorry.
So the answer in the chat, how many of the items listed in things, basically, so how many items should a little be displaying before you become concerned? The thing is every child and every human, I mean, we're all very different. And so I would say, if you are, one or two things that pop up, depending on the severity of those one or two things and kind of what those one or two things are, may not be enough to cause concern for someone. But if you're seeing multiple markers, so red flags or markers, or perhaps you're seeing some really extreme markers, definitely chat with your pediatrician, chat with your PCP, and ask them, like, I'm seeing these, how many of these things are typical behaviors? That pediatrician or PCP may, observe them in an appointment. And based on kind of what they're seeing, they may say, well, there's enough here that it may be worth your while, or you may want to go get them assessed. And so unfortunately, I don't have an answer where it's like, if there's 4 present, you should do blank. But, again, if you're seeing several markers, and they're happening at a frequency and they're happening enough that maybe they're interfering with the individual's learning or ability to do things, that may be at a time that you should look at, do we look at doing that? Because best case scenario, there's 2 best case scenarios here. Best case scenario, you take your little person in and they're not on the spectrum. They're not, nothing is diagnostically happening. Best case scenario, they are on the spectrum, or there is something happening, and you just allowed them to get a diagnosis to hopefully open the door to intervention early. So it's a scary thing for parents and caregivers to take their child or little one in because they want the absolute best for them. But again, you're the voice. And so either way, you have open doors, and, perhaps given them access to things that they would not have gotten had you not been the voice for them. So great question. Other questions or thoughts?
Kari, I know we had a couple of individuals on our panel today that were coming to be part of it. And I was wondering if that are in the professional field, sorry, that this might not be about their child, but if they have someone that they work with, either in a childcare setting or in when they get to school and things like that, and they're noticing symptoms, I know there's no easy answer for this one in the sense, but like easing into bringing up and broaching the subject with parents, is there any good tips for that you would suggest in all your years of being part of this?
Yeah, so yeah, that's hard. And so, but I can answer. I'm going to try to answer. Just brief background. I actually worked in childcare prior to working in the mental and behavioral health field. So I've worked with parents and families for actually, fully going to admit my age here, 20 years now then. So that is a really hard topic to broach because for a number of reasons. Depending on how familiar you are with the parent or caregiver, depending on the relationship you have established with them, these are all variables that, would perhaps change the topic. But if it's someone that you have a closer relationship with, depending on kind of how long you've worked with them, setting a parent down or chatting with them privately and just maybe, you know, engaging them in a conversation, letting the child play and just be like, you know, hey, I've noticed in my interactions with this kiddo that, you know, I'm seeing this, or perhaps I'm not seeing this, you know, and based on kind of what I know about development, I've got a little bit of a concern about, you know, X, Y, or Z. Now, if it's someone that maybe you're not familiar with, you know, let's say if it's a school setting, having the school psychologist or someone perhaps give the family a measure like the MCHAT to have them complete it, to look at from that perspective, maybe there are some symptoms available. That might be another route to go, is having another professional who maybe has that background, because teachers are exposed to so many students and so many things, and they are great resources, but it can be uncomfortable for them to broach that topic with parents and caregivers. And so, you know, talking to your resources as a teacher in the school, such as a school psychologist or social worker, may be another route to go to bring up those concerns. But if you don't feel comfortable, or perhaps you don't feel like your voice will be heard, maybe they would feel a little bit more comfortable, or maybe the parent would receive it a bit differently. John, does that answer the question? Okay. Other questions? These are great questions. Well,
okay, we don't seem to have any bubbles in the chat, Kari.
No, that's okay. Well, on that note, I greatly appreciate you all joining today and asking the questions that you asked. And I hope you found it informative. And I hope, you know, even if it just elicits other questions or it has information that you can share with other community partners and members, that's wonderful. So.
Well, thank you so much, Kari. A wealth of knowledge and things to take out to our panel here today that came and be part of it. We want to thank once again the Kansas Children Cabinet and Trust Fund, and they're all in for Kansas Kids Quality Subgrant, and thank them very much for their support of this great presentation series we are doing. We would also like to thank everyone who participated today, and remind those who participated today, last chance, if you have not signed up before and do not have an email address through signing up to us, we would really appreciate that in the chat right now, because we will send out a follow-up email with the presentation from Kari, some information about her, as well as a follow-up survey that will, every time it gets filled out, helps us gather knowledge and data for our grant that we get back to the wonderful people from All In for Kansas Kids, and helps us put on more of these wonderful presentations. So one last time, thank you, Kari, so much for an amazing presentation, and we appreciate your time. We appreciate everyone's time for being part of today's Parent Cafe.
Oh, you're